Hello everyone. Today I'll be talking to you regarding neurology test. Okay, and I'm sure all of you have gone through the questions, right? First question. Let us see what are the important points. We have a 35-year-old woman. She has a 3 weeks of tingling in right hand and left foot. This is very, very important point. It is right hand and the left foot. They are not on the same side. Point to be noted. She had 1 year back, she had an episode of blurring of vision in her left eye that lasted for a week and it resolved automatically. Blurring of vision. Now, when you examine the patient now, you are finding reduced sensation in the right hand and the left foot. The point for which she came, we are finding less sensation, paresthesias, but vision is normal. Now, which of the following feature is the most common early in the course of this disease? It's a beautiful question. So first of all, we should know what the disease is. Then only we can know what is the common in the early in the course of the disease. So definitely, it is just like searching the thing. Again, we go back to the question. First of all, she is a lady patient. Okay, she is a 35-year-old lady patient. Again, important point. And she has problem in the right hand and the left foot. They are not on the same side. They are different sides. That means there is a problem in the space problem. And she had one episode long back. This is a time problem. So there is a spacing in time and spacing in the place, right? And this the classical feature that goes in favor of multiple sclerosis, right? So best answer and one of the earliest feature of the multiple sclerosis is lethargy. Lethargy is one of the most common early feature. This is the answer of this question. So before we discuss more about multiple sclerosis, let's learn the basic concept about multiple sclerosis, what the disease is. So basic concept, this is the cell body. And we all know very well the cell body of every neuron, they lie in the gray matter. Gray matter or in a ganglia. This is a universal truth. And the fiber, they lie in the white matter. Okay? This lie in the white matter. Now, these are surrounded by myelin sheet. And we have a node of Rennewehr. All of us are aware that we have node of Rennewehr. And due to this node of Rennewehr, there is saltatory conduction. That means impulse jump from one node to other, and this is known as saltatory conduction. Saltatory conduction. That's why the velocity is very high in case of myelinated fibers, right? So now what happened, what the basic pathology in case of multiple sclerosis? This is gray matter, cell body, and this myelin sheet disappears. So that's why we call as multiple sclerosis as a demyelinating disorder. demyelination, right? So definitely when the myelin sheet is gone, one feature will be that conduction velocity will reduce. Very obvious. This is a classical feature that we will get in case of multiple sclerosis. Now one more thing you have to understand. These nerve fiber which I have mentioned you, they are there in whole body. Everywhere there are millions and millions of neurons in the body. So in this, every myelinated fiber will be affected. So that means any nerve can be involved. With the result, patient can have various type of features, various type of clinical features depending on which nerve is involved. This is the classical feature. Now what description is the classical about multiple sclerosis? There are two things. The lesions are space. They are separated in space and time. This is the classical finding. This is the most important in the understanding of subject. The clinical features are they are distributed over space and time. Again, to learn this, we go back to our question. Then you understand better. So we go back to patient. Well, here what we are getting, patient has come to us right now, but she had the problem of right hand and the left foot. Right hand and left foot. That means the lesion is at two different places. This is known as distribution in space. Now time, she had a problem. 1 year back she had a problem in the eyes. Now again after 1 year she has come. That means time gap is there. Distribution, okay. So the problem is time and space. So friends, whenever you will get a question on multiple sclerosis, you will be getting this word. If you are getting like this one hand or one leg, which you cannot explain by single lesion, this is known as distribution in space and time. Patient had a past history. This you can even write like past neurological problem. Neurological problem. If you are getting this is a golden line to remember. Golden line. If you are getting 99%, you are dealing with multiple sclerosis, right? So one extra point, it is more in females, like our patient is also 35 years, female in the age of 20 to 40 years. So friends, the golden line, a female in the age of 20 to 40 years, who have neurological feature distributed with space and time, this is multiple sclerosis. And one of the earliest feature is lethargy. It is seen in around 75% cases. Lethargy, fatigue are the earliest feature in this patient, right? So I hope you understood the meaning of lethargy, the answer. These are all late features. I'll be discussing in due course of this discussion. They are all late features. They do not. Initially, the patient come to us with lethargy, right? Now, little bit extra point. Risk factor. Who are the patient who are likely to get multiple sclerosis? Females, as I mentioned to you, much more than. And the age is 20 to 40 years. Invariably. Okay. Now, positive family history, quite possible that the lady who is coming to us may have the positive family history also. That anybody, maybe in the family, maybe sister or mother, may be suffering from the disease. Again, a point which really support our diagnosis of multiple sclerosis. But this is very, very important point. Now, one more thing, when the patient has full-blown disease is there, then there is a we call as classical so-called Charcot triad. Okay. Well, what are the three components? But point to be noted, this is not seen in all the patients. But if they are there in a patient of 20 to 40 year female, it strongly suggests that patient may be having multiple sclerosis. The features are dysarthria, nystagmus and intention tremor, Charcot triads. Classical features, and of course in our question they are not, because our patient has come in the very early stage, but these are happen in due course of time. But this is a chronic disease. How they manifest, I'll be talking to you in the due course of discussion, and later on again I'll come back. Who are the people who are bound to have Charcot triad? Okay. Anyhow, this you should know very well. The mnemonic is DIN, D for dysarthria, I for intention tremor, or N for nystagmus. DIN is the mnemonic to remember it. Well, as I told you, lethargy is the most common early feature, seen in as 75%. As I mentioned in the previous also, other feature which can occur in a patient of multiple sclerosis, but they occur in the late. They are never early presentation. So now let us see what are the usual features that we are likely to be seen in a full-blown patient. Of course, I did mention about Charcot triad. Now, what are the other features we are bound to get in a patient of multiple sclerosis? Visual, optic neuritis. This is the classical thing. In fact, whenever you will get a question on multiple sclerosis, quite possible they will talk about optic neuritis. It may be a common presenting feature, like in our patient also. Patient has problem 1 year back. That means it was a presenting feature. But this need more discussion. First of all, everywhere they write as optic neuritis. In fact, the actual word is retrobulbar neuritis. This has a meaning, special meaning. Again, we go back to basic. This is the optic nerve, and this optic nerve is going to the brain, and here is the myelin sheet. Okay, and in these patients, this myelin sheet disappears. So it become like this, right? Or I can show you, okay, that there is one. This is the normal. Let's say this is normal, and this is abnormal or demyelinating. One classical feature in multiple sclerosis, optic neuritis is unilateral. Again, a gold medal line to remember. This is unilateral. Point to be noted. Number two, as the demyelination occurs, so what happens? So the conduction velocity in this eye will be reduced. Conduction velocity in this eye will be reduced. Why? Myelin sheet has gone. But in this eye, the conduction velocity is same, normal. What will affect? This will affect the vision. Vision will be disturbed. For everything, the patient will be getting two images. Write down. Patient will be getting two images. Why? What do you mean by two images? Suppose the patient eyes, they are reading this. A is written. They are watching on the board and they are reading A. This A will come to brain very fast. Maybe it comes in 100 milliseconds. But this A, by this will come after 200 milliseconds. It will come late. Why? Velocity is slow. The patient will be getting two images of one single word. That disturbs the vision also. But addition to that, golden line to remember, patient has vision problem, but what they say, doctor cannot see. Patient cannot see. What do you mean by this? When the patient, well, the problem is retrobulbar. It is behind the fundus. So when the doctor will examine the fundus examination, he will see no abnormality because fundus is clear. Problem is behind the fundus, and patient cannot see because there is a problem in the visual pathway. And I told you, one image is seeing two. He may have difficulty in watching also. The classical word is patient cannot see, doctor cannot see is talking about multiple sclerosis. Understood? In addition to that, Uhthoff phenomena. Classically, whenever patients take a hot bath, and whatever patient's complaint is, the symptom increase after a hot bath. Like our patient has come. She has come with the paresthesias, numbness in the one hand and the other leg. She will go for a bath, and when she come back after a hot bath, she will say, doctor, my problem increases. If the golden line to remember, if the problem increases after a hot bath, this is multiple sclerosis, and this is known as Uhthoff phenomena. Uhthoff phenomena. And in addition to that, internuclear ophthalmoplegia. This is, if you are getting this word, you are getting multiple sclerosis. So friends, got three things: optic neuritis, okay, and Uhthoff phenomena, and internuclear ophthalmoplegia. If any one of these is mentioned, most likely you are dealing with multiple sclerosis. Such an important point. Well, I told you the patient can have any problem, any nerve. If sensory system is involved, patient will have pin needle numbness like our patient has. In addition to that, patient can have trigeminal neuralgia. So again, trigeminal neuralgia patient will come with severe headache in the distribution of trigeminal nerve. It's a really severe pain. Although it may be, trigeminal neuralgia may be idiopathic also. Idiopathic is more common in males as compared to females. But if a female is coming with trigeminal neuralgia, always keep a possibility of multiple sclerosis. Always. And one additional feature is Lehermitz syndrome. Classically, when the patient bends the neck forward, okay, a current-like sensation goes in the limbs, and this is known as Lehermitz sign or Lehermitz syndrome. And paresthesia in the neck, in the arms or neck flexion, and this is also known as barber chair sign. So trigeminal neuralgia and Lehermitz sign are the two keywords that you got to remember. Motor spastic weakness. Now come the gold medal question. Spastic weakness indicates upper motor neuron lesion. Definitely it indicates upper neuron. In lower motor neuron lesion, you get atrophy. Okay, that's simple, basic. And due to spasticity, in case of upper motor neuron lesion, there's increased tone, and plantar are upgoing plantar. Yeah, that is okay. But what is so special about it? Friends, lower motor neuron palsy is not a feature. Very important negative point. Why? This is the upper motor neuron fibers coming. corticospinal fiber, corticospinal tract coming from the brain, ultimately they come to spinal cord and they relay in anterior horn cell. They relay in anterior horn cell. This is the anterior horn cell. We also know very well that from anterior horn cell, motor nerve comes. Motor nerve comes and that goes to the muscle. That goes to the muscle. This is motor nerve and this goes to muscle. Okay. Point to be noted that when we talk about lower motor neuron lesion, lesion is in the anterior horn cell or in the motor nerve. There are the two sites. There are the two sites where we have lower motor neuron lesion. Anterior horn cell and the motor nerve. But in case of multiple sclerosis, problem is in the corticospinal tract or above. That means demyelination occurs. These nerve, so problem is in the demyelination in the central nervous system. So that's why lower motor neuron palsy is not a feature of multiple sclerosis. Very, very important point. Okay. Well, there may be involvement of cerebellum. Anything can be involved that can lead to ataxia. In addition to that, urinary incontinence, sexual dysfunction and intellectual deterioration, it's a late feature. It's a very late feature. It's not a early feature, point to be noted. Very late feature. After many years, it can lead to. So friends, we learned a lot. And now if we come back to the question answer, so we are clear about it, that cognitive decline will be a late feature. Difficulty swallowing is feature more likely to be in myasthenia gravis. Okay, more likely. Muscle contracture will be seen again in case of muscle disorder or anything which can lead to lower motor neuron palsy, or again muscle contracture is not a feature. Is more of a fibrotic condition, not here. Speech disturbance is, this is not a feature. Why? Again, $1 million question. Because speech disturbance, remember, dysarthria can occur. Dysarthria is a defect in the peripheral where the sound is getting produced. But when we say speech disturbance, that means motor and sensory aphasia. Motor and sensory aphasia, that is Broca's, involvement of Broca's area or involvement of Wernicke area. Why can't speech disturbance not occur? Write down the answer in your copy and don't forget to WhatsApp me later on. But at the moment, don't waste time. Just write down the answer in your copy. Why speech disturbance cannot occur in multiple sclerosis? Quickly. Why speech disturbance cannot occur? Quickly, you got 30 seconds to think and answer. I hope you have written the answer now. So I asked you a question, which 3 things never happen in case of in multiple sclerosis. Parkinson is not a feature. Aphasia is not a feature. And epilepsy or seizure disorder are not a feature. The mnemonic is P, P-E-A. Mnemonic is P, P-E-N-A. These things don't happen. Reason, they are all gray matter diseases. Point to be noted, multiple sclerosis is a white matter disease. Understood? Yeah. So with this background of learning a lot of things, a basic, now my further discussion will be much easier because good amount thing I discussed. So now let's come to question number 2. we have a 33-year-old female. Well, oh, she's a case of multiple sclerosis and her vision become blurred during hot bath. Now your basic concepts are very clear. What is talking about? The symptom increase after a hot bath, right? So that is Uhthoff phenomena, right? This point I discussed previously. So this is Lehermet sign. Again, we see in multiple sclerosis, but this is on bending the neck forward. Bending the neck forward is so-called Lehermet sign. And okay, this is not and this is hot bath increasing is Uhthoff phenomena. So Uhthoff phenomena with a problem increase after a hot bath and Lehermet sign when the neck bends forward. Question number 3, beautiful question. You have been asked to do examination of lower limb of a patient with multiple sclerosis. Which finding you will not get it? Decreased tone. Why? Now your concepts are clear. This decreased tone is a feature of lower motor neuron palsy. And as we learned in the basic concept, lower motor neuron palsy is not a feature. Upper motor neuron are the feature. So patellar clonus, upgoing plantar, weakness and Brick's reflexes, they are there in upper motor neuron feature. You will definitely see, what about weakness? Of course, weakness does occur in lower motor also, but it occurs in the upper motor neuron also. But this occur only in lower motor neuron. Hence, decreased tone is not a feature. Remember, examiner says choose the most appropriate answer. This is seen exclusively in lower motor neuron. Question number 4. Again a 28-year lady. Point to be noted. We are getting a lady between 20 to 40 years. She has a 3-month history of increasing fatigue, lethargy. Okay. And increasing lethargy and muscle cramps. And episode of visual disturbance 6 months ago, and there were problem in the left eye and red color, and this symptom resolved spontaneously in 2 weeks. Blood values, you have said they are all seem to be normal. Most likely problem is what? Most likely problem is what? So again we go back to the question. 28-year-old lady, fair enough. 3 months history of increasing fatigue and increasing lethargy throughout the day, experience muscle cramps also. Other systemic examination are normal. And she had a visual disturbance 6 months ago, right? 6 months ago, and that was on the left side. And symptom resolve after 2 weeks. Lab tests are there. How much is the, okay, what's the most likely diagnosis? If this again, something very tricky question to answer. Only clue to us was that she had a 6 months back some eye problem was there. But now she's coming with just fatigue lethargy. Fatigue lethargy that can happen in so many conditions. It's not a diagnostic of multiple sclerosis, right? So let us analyze. So look into this. What about anemia? Can anemia have vision problem? No, it cannot have vision problem. Definitely. And moreover, HB here is about 10.5 gram. 5 gram percent. Or so this is not a severe anemia. And this 10.5 is fairly good HB. and this is not a reason to have so much of lethargy whole day ruled out. Fibromyalgia, it occurs in ladies, but they have a muscle stiffness. They have a muscle pain. And classically, they have a tender points. Tender points, there are 18 tender points. You press on those points and the patient cries with pain. And that is not a feature. And moreover, in fibromyalgia, vision problem is not a feature. Giant cell arteritis, straightway ruled out, is a disease of the above 50 years. It's not a disease of the patient of 28 years, ruled out, 100% ruled out by age only. And moreover, the giant cell arteritis patient come with the headache and superficial temporal artery tenderness. However, age is totally out. Myasthenia gravis, well, it is occurring in ladies beyond doubt, but they have a diplopia. They don't come with vision problem. They come okay, vision problem and they have diplopia type of picture is there, and moreover they have a muscle weakness, which is more in the evening hour. So it has altogether a different type of entity. So finally we ruled out all other options. Multiple sclerosis is a feature and supported by the feature that she is a lady, increasing fatigue, and she had a vision problem. Although there is no past history, other than there is no recent any definite CNS problem is not a feature, but still it goes in favor of, we ruled out other, so we are going more in favor of multiple sclerosis. Okay. Question number 5. We have a multiple sclerosis patient. Increasing problem with the painful involuntary contraction is a big problem which can occur in these patients. So what therapy we can give? Answer is baclofen. Okay. Remember, he has a increasing problem with the painful involuntary movement. We need urgent something which can take care of the muscle spasm. And baclofen is a wonderful drug to use in muscle spasm in these patients, right? So let's learn in great detail how we really manage a case of multiple sclerosis. And once our basic concepts are clear, basic concepts. How we manage a case of multiple sclerosis. Okay, there's no cure. Once the disease is there, it will be there. But what is our aim? Reducing the frequency and duration of relapse. But before that, let me explain to you what do you mean by this. The disease is like it occurs for some time. The patient may become normal, patient again come back, have some other problem, all right, again. That means patient has an episodic problem. So our aim is that we want that whatever, first of all, this gap should be increased. We want severity to be reduced and gap should be increased, so the relapse doesn't happen. This our aim is. We cannot cure it. And when the patient has acute attack like this, acute attack, what to do and what medication we will give you so that it doesn't happen. So there are two aspects of treatment. First is to take care of the acute relapse. Patient has come with acute problem with you. What to do? In such cases, we give high dose steroid, so called we give methylprednisolone intravenous. So write down. For acute relapse, you give intravenous methylprednisolone intravenous. It's given as a pulse therapy for 5 days. You give IV for 5 days. You will take care of the acute problem immediately. Okay? Right? So this is what we are doing immediately. Later on, our second aspect is we want that relapse should not happen. So we give certain disease modifying agent, so-called prophylactic drug. Remember, disease modifying agent we give in rheumatoid arthritis also. Of course, there are different diseases, but different drug. But idea is that relapse should not occur fast. The gap between the two acute attacks should increase. That's the idea of giving disease modifying agent. The best drug that we use is beta-interferon. It's the best drug, most widely used drug. Why? It is a safe, not much of side effect. So it's the most widely used, and it can reduce the relapse rate by 30%. So it's a very so safe, no side effect, and very effective. Right? But point to be noted, it's not going to reduce overall disability or the it's not. It will, but a problem has to occur. It will occur due course of time, but definitely much later. It will simply prolong the duration of onset of the problem. So the disease modifying or the drug that we use for prevention of relapse is beta-interferon. Point to be noted, it is not for acute attack. For acute attack, you have to give methylprednisolone. We can use other drug also. Again, they are preventive drug, glatiramar. This is second drug that we very widely used drug. Okay. Then we have a natalizumab. Oh, wonderful drug. It's a monoclonal antibody. It's a really very interesting drug to talk about. When we use this drug, it's a very good drug. But in some cases, it can cause increased demyelination. Increased demyelination, you mean to say it's going to aggravate multiple sclerosis? Yes. But now comes the gold medal question. Who are the patients where this problem can happen? Write down the answer in your copy. My question is, who are the patients where we give natalizumab and that lead to more and more demyelination? That means the patient problem will aggravate. Definitely MS is a disease of demyelination. Write down the answer. Yes. It may cause reactivation of JC virus. And JC virus is notorious to lead to demyelination. About this point, I'll be talking to you little later on in some other question. But as of now, write down that natalizumab is a one drug that can lead to demyelination. It's a very frequently asked question I've seen. Fingolimod is again one more demyelinating, is a disease modifying agent. In addition to, so we learned about how to manage an acute attack, and we learned what all drugs we can give for as a prophylactic drug. But there are so many other things that patient need to be treated right now. Fatigue. I told you fatigue is a big problem. And one more thing, before we really talk about fatigue, treatment, rule out anemia, thyroid or depression. These patients are really depressed. Why? Because they know, because they have been suffering from the one disease or other problem. 6 months back, a patient may be having eye problem. Now she has sensory problem. Maybe after some time, she may have motor problem. Right? So they are under depression. And she's a young lady, 30-year lady, totally fatigued. So she are bound to get depressed. But again, before we really label fatigue due to MS, you must rule out anemia and thyroid profile. Rule out hypothyroid. This is as per NICE guidelines. Rule out hypothyroid. Second problem is spasticity, for which we give baclofen. This we discussed in the previous question also. And we can also give gabapentin. gabapentin, and remember this gabapentin we use for neuralgic pains. In spasticity, the big problem is there, they have pain also, and of course in addition to this drug, we can give physiotherapy is very important, so patient is strongly advised to go for physiotherapy. Bladder dysfunction is again a big problem in this patient. Now extra edge point of view, one thing, gold medal line, we have other disease called GBS, so-called Guillain-Barré syndrome or Guillain-Barré syndrome, right? So in this also demyelination occurs. But main thing is in Guillain-Barré syndrome, bladder dysfunction is not a feature. If you are getting a patient where you are suspecting the case of Guillain-Barré syndrome, also called Guillain-Barré syndrome, and the bladder is involved, then perhaps you are not dealing with GBS, you are dealing with something else. Such an important point. But here we are talking about multiple sclerosis. Well, in this we can talk about intermittent catheterization, okay, especially if residual urine is significant. But if residual urine is not, then we can go for even anticholinergic can be used. This is going to reduce the bladder frequency. Okay, so friends, with this basic concept, the question was, the patient has painful involuntary movement, what we'll give is baclofen the answer. Well, with the following drug is in the management of multiple sclerosis. If you look into this, all of them are. Now again, very confusing question is this. He says in the management of multiple sclerosis. Okay, if you look into the options, beta-interferon, we know that we use as a prophylactic drug. Do we use gamma-interferon? No. Infliximab, no. Rituximab, oh, none of. Now my job is very easy. We know the basic concept. None of these we use in the management. Point to be noted, he did not talk about steroids. He did not talk about steroids. These straight away, we have learned, now our basics are very clear, so we know none of them drug is used for multiple sclerosis. But now question was, suppose in place of alpha interferon, E option was steroid, what to do? Then he would not have asked you this question. Then the question would have been management of multiple, then management he will have acute management. Then the word would have been acute management. That means what you will do right now. Then the answer becomes steroid. Or the word would have been in prophylactic management. Then the answer would have been beta-interferon. Got it? So no, because we used to be very, your mind should be very clear. What question they ask, what answer I have to give. And one more thing, as of now, if you are getting beta-interferon anywhere, it is multiple sclerosis. Because alpha-interferon and gamma-interferon we use in many other conditions. But beta-interferon, as of today, we use only in multiple sclerosis. So you can say the golden line to remember. Beta-interferon means you are dealing with multiple sclerosis. So simple, golden line to remember. Question 7, we are getting a 21-year-old lady, blurred vision, pain in right eyes, which worsen after morning bath. Oh, she talk about Uhthoff phenomena. Similar symptom happen on the right eye. Oh, right eye. Point to be noted. Point to be noted, same place is there. Same place, right eye. But that is all automatically without taking any. Okay. Now if you look into right optic nerve, there is no much of the problem, and lumbar puncture demonstrate oligoclonal band in CSF. Mother has a multiple sclerosis, right? So, if you look into the question, she is a 21-year-old lady that fits into the category of age group which is of multiple sclerosis. Agreed. But that is not the answer. Here there is right eye and right eye. That means she has two attacks of eye involvement. So there is a time gap is there, 6 months apart. But sight remain the same. Sight remain. That means there is a time gap is there, but space, sight remain the same. There is no same places there, right? The only one supporting thing is that even in the CSF shows increased oligoclonal band. This is again a feature of that we see in MS. But before I talk more on this question, let me tell you about what investigation do. What investigation we do in any case of multiple sclerosis. Now come the gold medal question. What is the best initial test? For a case of multiple sclerosis? Write down the answer in your copy. Second, what is the most accurate test to diagnose a case of multiple sclerosis? The two different questions. What is the first initial test and what is the most accurate test? Write down the answer quickly. I am sure you have written the answer. Answer for both is MRI. MRI. Right? So, and of course, other supportive investigations are evoke visual potential. Evoke visual potential. Here we measure the conduction velocity of the two optic nerves. So definitely, as we discussed in the previous question also, in the myelinated fiber, suppose the impulse reaches in 100 millisecond. In demyelinated, the impulse will reach maybe after 300 millisecond. So there is a difference in the conduction velocity is different, and that's why I told you. The patient is watching one figure. Maybe he is watching A. In this A, it reaches in 100 millisecond, and other it reaches in 300 millisecond. One more question for you. Write down the answer. Tell me, which is the visual center in the brain? That means you are watching the screen. It is being seen by your eyes. But this picture is going to which part of the brain? Write down the answer in your copy quickly. Which part of the brain? The answer is occipital lobe. Occipital lobe is the center of vision. Got it? Now the two A's, one A is coming now and one A is coming after 300 milliseconds. So your occipit or your brain is seeing 2A, and this is known as pulfric effect. Pulfric phenomena or pulfric effect is too visual. So visual evoke potential is like this. Now MRI is positive in 95% cases. It can give you evidence. But in 4 to 5% cases, even MRI may not be giving you important features. So first of all, whenever we are talking about MRI, brain MRI is done beyond doubt. But otherwise, we can go for spine, Like in this case, we already previously she had a right eye, again she had the same problem in the right eye. So there is no point in doing the brain MRI. So now in this case I like to go for the spine MRI, where I like to look for the demyelinating plaque. Plaques will be there, because MRI done in the past had shown some problem, right? So friends, we talk about MRI, we talk about visual evoked potential, we talk about brain MRI, spine MRI. But there is oligoclonal band. We do CSF examination and look for oligoclonal band. But this we see, and this is again a add-on diagnosis, especially when MRI is normal. Okay, oligoclonal band is there. So we know, so what are the important things that we go to diagnose a case of multiple sclerosis? So patient has come to us and we don't want to waste time. Start beta-interferon? No way. It is not a treatment of acute. It's a prophylactic. Reassure that she doesn't have MS and discharge? No way. No way you can say she already had problem 6 months back. Okay, 6 months back problem, again she has a problem. So no way, you can't send her home like this only. Visual evoked potential is not the, is add-on, is not the first line investigation. Give steroid and array, repeat MRI as a neurology outpatient? No, you cannot leave the patient for outpatient. No way. Because this problem, you cannot. It has to be given pulse therapy for 5 days. For that you have to hospitalize. Hence, other are not. Hence, this is the best answer in this question. Again, by direct way and also better way is by rule out technique. One more thing you learn, whenever you have a doubt in answering, rule out other option. So one is a direct answer, one is the rule out technique. In case of doubt, always go by the rule out technique. Okay. So friends, for multiple classical line, require demyelinating lesion that are separated in time and space. In our question, same right eye is involved. Time gap is there, 6 months, but space is not, because the site of lesion is the same. So we need to really go into the proper way to diagnose and treat the case. Okay. Right? Now we talk about question number 8. Again, we are getting a 43-year-old lady. Acute confusion, legs weakness and behavior disturbance. She has a past history of multiple sclerosis, for which she is taking natalizumab. Oh, we read about this drug. Okay, let us see. But now she is not oriented to time and space and is very aggressive. This aggressive behavior is usually not seen in multiple sclerosis. Depression is seen. And weakness is there in the left leg. Fine. Past history of multiple sclerosis, we can understand. Leg weakness, we can understand. But this is something, not a feature. Let's see what's the problem. Okay. If you look into the investigations, WBC count is high. And rest all the investigations are within normal limit. Oh, CRP is raised. This WBC count is increased and CRP is increased. And definitely, and CRP is 78 as compared to normal 5. And we all know very well the CRP increase in any inflammatory phenomena. And raised CRP is not a feature of multiple sclerosis, not a feature at all. There is some other thing is going on. So what is the most likely? Answer is progressive multifocal leukoencephalopathy. Why? It's one disease, natalizumab, as I mentioned earlier, which is a monoclonal antibody. It causes reactivation of JC virus, especially in those patients who are a case of HIV. So in HIV patient, it leads to activation of JC virus. And the JC virus which lead to progressive multifocal leukoencephalopathy, what we write as PML. Now, in PML, it is a demyelinating disorder. Picture mimics like multiple sclerosis. Got it? So friends, the point which I mentioned in the previous question, that when we get a natalizumab, and that now after natalizumab the problem has increased, and now she has again come with the left weakness, and moreover aggressive behavior is there because there is involvement of the brain now. HIV patients are there, and moreover diagnosis is supported by increased CRP and the WBC count. Can it be bacterial meningitis? They come with high grade fever. The patient doesn't have fever. Autoimmune encephalitis. We didn't get any clue. Or moreover, in autoimmune hemolytic anemia or encephalitis, okay, some autoimmune process should be there. There's nothing like, there's no clue regarding autoimmune. Intracranial hemorrhage, they have severe headache. Altogether different personality. And toxoplasmosis, again, we need to have some other features which are supporting it. There's no clue that patient has. Normal toxoplasmosis patient may have even seizure also. But there's nothing which indicate toxoplasmosis. But this is a well-known direct. Now this can be go by direct also. We don't need to go for rule out technique. We are well aware that natalizumab lead to the activation of JC virus can progress to PML. So remember, golden line to remember, natalizumab increase features of multiple sclerosis equal to JC virus. Golden line to remember. Natalizumab patient, now he has increased problem of more of multiple sclerosis problem. Like problem is JC virus activation. Question number 9. 32-year-old lady with 2 children, double vision, had an episode of acute vertigo, and pattern of is most likely in the first year of the life. Something very interesting. What they are talking about, what he is asking about, you must have read the question very clearly. We have a patient of multiple sclerosis. What pattern is there? This is again a very commonly asked question. I'll first tell you the basic concept, then again I'll come back to the answer. So, disease pattern are as follows. That means a patient of multiple sclerosis is in front of you. What type of pattern of illness can be there? Let's learn. One is known as relapsing remitting MS. MS is multiple sclerosis. Relapse remitting. So we write as RRMS. Relapse remitting multiple sclerosis. This means patient has problem It occurs and goes, occur and goes. It's a classical, but I also described in the previous questions. Patient has problem, but when the disease disappears, he become perfectly normal, no permanent deficit. Point to be noted. This is relapse remitting, no deficit, no permanent deficit. Once the disease phase gone, the patient become all right, and that's what we wanted. In fact, what I told you, when we use the disease modifying agent, what we want, we know attack will happen. This is the normal what can happen. But our aim is we want to convert into this. That is the idea of giving disease modifying agent. Anyway, the course of disease is relapse remitting. Fair enough. Second type is secondary progressive MS. S for secondary progressive SPMS. Previous one was RRMS, relapse remitting. Here we have a secondary progressive. Let us see what is that. Initially, patient has the way we have RRMS, the previous one. But after some time, it starts like this. It is progress now. Initially, it was just like RRMS, but now it is progressing. So now, after each attack, patient has some deficit is there. It's not completely cured. This is so-called SS, secondary progressive. That means initially RRMS, later on it start going into progression. Then primary progressive, from day one it is increasing. Day one it never came back. It's going bad, so-called PPMS, primary progressive. Okay, so from day one only the problem is increasing. The previous one was RRMS, and later on it start increasing. Fourth one, progressive relapsing MS. Okay, that means it is just like this one. This one is the primary progressive, but here primary progressive also. Oh, suddenly it has got further flare up. This is what we call as, what? Progressive relapsing PRMS. So friends, a quick recap. RRMS. Then secondary progressive. Primary progressive. And finally, you get progressive relapsing. So all the four types you can see in a single frame. Got it? This is the course of the disease. With this background, now we come back to our answer. So, symptom affecting peripheral nervous system first and central nervous system later. This is wrong. It is a primary disease of the central nervous system. Rule out. A slow and gradual accumulation of symptom over next 20 years. No way. It's not. It can have different type of pattern can be there. Rule out. Symptom gradually ascend up her body starting with the foot drop. No, what he says, because problem is in the leg, or later on it can come. No way, it can have anywhere. Rule out. Rapid accumulation of new symptom initially but slowing after 10 years. No, it is always a progressive disease. So all the four options are ruled out, and what are occasional flare of new symptom in different area of body with variable recovery in between. I think it's the best answer. Beyond doubt, you rule out all other options. question 10. Now we are getting, 70-year-old men. But since yesterday he is clumsy and unsteady on the feet, is not stable. Numbness down his left side. Right-sided Horner syndrome. Nystagmus. Sensory loss on the left side. The answer is where the lesion is. Answer is posterior inferior cerebellar artery. But before I come to the basic concept, let me look into the question once again. Problem is, look into the patient is a 71-year-old man. Is an elderly person. Second point, the problem has been there only for yesterday. It's an acute onset, sudden onset. Second keyword. The first keyword is the age. Is an elderly person. Second is sudden onset of the neurological deficit. Third is neurological deficit. With this background of age, the most important is sudden onset. Let's talk, and again I come back to question. This is a patient of stroke. Now, what is stroke? It is abrupt onset of non-convulsive. The only other thing that can have an abrupt onset is convulsion. So if you rule out convulsion, so abrupt onset of any focal deficit and that lasts for more than 24 hours is stroke. Write down this definition. Spell it out, write down what I have marked with the yellow pen. Abrupt onset. Focal deficit lasts for 20. First keyword, focal deficit lasts for more than 24 hours. Friends, learn the golden line. In neurology, anything which is of sudden onset, in neurology, anything which of sudden onset is vascular. It is a golden line to remember, unless proved otherwise. So any question where you are getting sudden onset of deficit is stroke, like this patient, right? Or well, it may or may not recover within 24 hours. It doesn't recover in 24 hours, we call a stroke. But if it recovers within 24 hours, then we call as transient ischemic attack, TIA. The only difference between the TIA and stroke is duration of recovery. Less than 24 hours TIA, more than 24 hours is stroke, right? Understood. Let's learn more basic concept about stroke. So, what I told you, TIA deficit is there, but it resolves within 24 hours, the point I mentioned in the previous slide. But there are certain very important points. TIA is always ischemic. It is never hemorrhagic. It means what? A TIA patient come to you right now, you are sitting in the OPD right now. Okay, doctor, I had, you know what happened, when in the morning when I got up at 7 a.m., there was complete left-sided, both upper and lower arm were paralyzed. Okay, but now it was in the 6 a.m. in the 7 a.m. But now, after 3-4 hours, I perfectly became all right. And he come to you. He says, "Oh, I'm perfectly all right." What you are getting? He's talking about TIA. and it is never hemorrhaging, never ischemic. So you will immediately start with the antiplatelet drug, especially aspirin, very safely, because it's never hemorrhaging. Okay, so I hope you understood the point. So with this background of stroke, so let's learn. We'll talk about stroke. When we talk about stroke, maybe anterior circulation, or it may be posterior circulation. In anterior circulation, there is involvement of anterior cerebral artery and the middle cerebral artery. In the posterior circulation, there is involvement of vertebrobasilar artery. VBA is vertebrobasilar artery, or there may be involvement of posterior cerebral artery. So first, at the moment, we learned about what happened in the posterior circulation, and then later on we'll talk about anterior circulation also. So in the posterior circulation, the single most lateral medullary syndrome, this is one of the most VVIP topic. This question comes throughout the world, but this you will never understand unless you know the anatomy. So let's learn about anatomy of the medulla. This is the medulla. This is inferior cerebellar peduncle. This is the 10th nerve nucleus. This is the 8th nerve nucleus. This is the 5th nerve nucleus. And this is the sympathetic chain. Sympathetic chain. And here is the spinal lemniscus. So before I proceed further, let me tell you something about spinal lemniscus. This carries touch, pain, touch, temperature, fiber from contralateral body. Contralateral body. So let us presume that we are dealing, this is the right side. Right-sided. So this spinal lemniscus, they are carrying pain, temperature from the left side of the body. Okay. So in this part of the brain, this part of the brain is supplied by pica. Pica is the posterior inferior cerebellar artery. Okay. So this part, pica, is posterior inferior cerebellar artery. These structures are involved. So how this patient will manifest? Now you first, okay, look into cerebellar peduncle is involved. So definitely this patient will be having right-sided cerebellar features. Right-sided 10th nerve palsy. Right-sided 8th nerve palsy. 8th nerve is vestibulocochlear nerve. 5th nerve palsy, which supply the face, and sympathetic chain, and that will lead to Horner syndrome. But there will be contralateral loss of pain, touch and temperature. Why? Because spinal lemniscus contain fiber from other side of body. So first you write down the features of lateral medullary syndrome. Now you can write down. It is written for easy convenience. Okay. You can see this is known as lateral medullary syndrome. This is also known as Wallenberg syndrome. So we have a ipsilateral cerebellar lesion, the reason I told you. 10th, 8th, 5th and Horner syndrome. Contralateral loss of pain touch temperature. Why? Because they carry contralateral fibers are there. Okay? Understood? This is lateral medullary syndrome. With this we come back to our question again. We are getting a patient who has come with problem of one day it is a stroke. Anything acute onset is with some deficit stroke. Unsteady on his feet because of cerebellum involvement. Okay, and he come numbness in the left side of the body. Why? Because of spinal lemniscus involvement. So he is having left-sided sensory problem. But right-sided Horner syndrome. Right side, left side. Okay, and sensory loss on the left side. So what we are getting? We are getting unsteadiness. He cannot stand. This indicates cerebellum involvement. He has a Horner syndrome on the right side and he has a sensory loss on the left side, and they are all going in favor of pica syndrome. One more thing, golden line to remember. If you are getting a stroke patient having Horner syndrome, you are dealing with lateral medullary syndrome. Golden line to remember. You are getting a stroke patient having Horner syndrome, lateral medullary syndrome, so-called artery involved is pica, posterior inferior cerebral artery. This is a universal question. It will come to you also in the exam 100%. So I'm leaking the paper, but in a very honest way. This is very frequently asked throughout the world, whichever exam you write. Okay. So we learned a lot. Now let me talk about little bit extra point. Little extra. Here is the corticospinal tract. We all know very well they will go down and they will cross to other side. They will go down and they will cross to other side. Here is the 12th cranial nerve. 12th cranial nerve. And here is the medial lemniscus. This red color is medial lemniscus. Again, a basic concept about medial lemniscus. It contains contralateral position vibration sense. P for position, V for vibration sense. The contralateral body. Remember, we have a spinal lemniscus which contain contralateral pain, touch and temperature. They contain contralateral position vibration sense. Now this part of the brain is supplied by a branch of vertebral artery. This part is supplied by the branch of vertebral artery. So how he will come to us? He'll come to us with ipsilateral 12th nerve palsy. 12th nerve palsy, same side. Contralateral hemiplegia. Hemiplegia, why? Corticospinal tract is involved. Contralateral loss of position vibrations. Why? Medial lemniscus. And this is known as medial medullary syndrome. Make a box of this line. So friends, in the medulla oblongata there is medial medullary syndrome and the lateral medullary syndrome. Make a box of this. Ipsilateral 12th nerve palsy, contrahemiplegia, contralateral hemianesthesia is medial medullary, and the artery involved is a branch of vertebral artery. And I'm sure you have made a box of this line also. Very, very important, Wellenberg syndrome. So you got two important golden lines to remember in the medulla oblongata. Then we talk about in the pons. This is the pons. Here is the corticospinal tract. Here is the 6th nerve. Here is the 7th nerve. And it revolves around the 6th nerve and come out. Pons. Now this part of the brain is supplied by ICA. The previous one was pica. This ICA is anterior, inferior cerebellar artery. And what it lead to? It will lead to what? Ipsilateral 6/7 nerve palsy. It is there. And that lead to what? Contralateral hemiplegia, because this corticospinal tract, this is a corticospinal tract which is going to go down to medulla and will go to other side. So ipsilateral 6/7 and contralateral hemiplegia is Millard-Gubler syndrome. Now let us see one more thing. We got one patient, 6th nerve, 7th nerve, okay, 7th nerve, 6th nerve, and we get a basilar artery. We get a basilar artery, and basilar artery supplies the pons. Okay, let me give you example. This is the two vertebral artery. They unite to make basilar artery, and this is the pons. And the basilar artery, they supply the pons. At times the lesion occurs in the basilar artery. So bilateral supply of pons goes away. Okay. So what will happen? This is known as locked in syndrome. Locked in syndrome occurs when the lesion occurs in the basilar artery. How does patient manifest to you? Look into this. He will have bilateral 6/7 palsy. Bilateral. And he has bilateral hemiplegia. So friends, bilateral 6th and 7th and bilateral hemiplegia, which is equivalent to quadriplegia. He will not be able to move his limb at all. All the four limbs gone. And his 7th nerve are gone bilateral. He cannot move the face also. His bilateral 6th nerve gone. 6th nerve is what? It has the lateral rectus. Okay, he cannot move the lateral rectus. In fact, we have a gaze center. Gaze means like, look, I am looking right side, I am looking left side. This is the what? Horizontal gaze. Even horizontal gaze center is in pons. So this patient cannot even look up lateral side also. But vertical gaze center moving up and down, this is there in midbrain. In midbrain. So this locked in syndrome, only movement what is possible is up and down. Up and down is that we see in locked in syndrome. It's a very commonly asked question that in locked in syndrome, which movement is possible? Only movement possible is up and down. Up and down is the vertical because the center lies in the midbrain. So locked in syndrome occurs due to what? Basilar artery. And Miller-Goodman occurs due to anterior inferior cerebral artery. Okay, so you are clear about locked in syndrome also. So locked in syndrome, complete paralysis, that is quadriplegia. Patient is conscious and preserve upward eye movement, very, very important point. So preserve upward eye movement and complete quadriplegia is what we call a locked in syndrome due to basilar artery involvement. Then let's talk about some lesion in the midbrain. Again, let's go to the basic concept. Okay, midbrain. This is the corticospinal tract. Here is the third nerve. And this part of the brain is supplied by branch of posterior cerebral artery. Branch of posterior cerebral artery. How he will manifest? There will be ipsilateral third nerve palsy and there will be contralateral hemiplegia, and this is known as Weber syndrome, a universally asked question. Ipsilateral third nerve palsy, contralateral hemiplegia is Weber syndrome. So make a box of this also. This is a midbrain lesion. With this background, now let's come to the question, what we learn. So, what I told you, here is the pica is the involvement. Why? What a keyword, Horner syndrome. This we don't get in any of the other. Straightway you can jump, and of course this contralateral sensory loss is there. That indicates we are dealing with pica. Lateral medullary syndrome is caused by, now the things are very clear, is a pica, lateral medullary syndrome. The basics are very clear, so no need to talk more on this. Now we talked about the posterior circulation. Now I'll be talking to you regarding anterior circulation stroke. Anterior circulation. Just to remind you, in the posterior circulation we talked about medulla, pons and midbrain. Anterior circulation. For that, we learn the basic anatomy. Basic concept. Here is the brain. This central sulcus. The part which lies in front is the whole. This whole is frontal lobe. This is a lateral sulcus. This is the central sulcus. This is parieto-occipital sulcus. Central sulcus, lateral and parieto-occipital sulcus. The part which lies in front of central sulcus is the motor cortex. In the motor cortex, leg area lie at the top and the head area they lie at the bottom. Similarly, just the part which just lies behind the central sulcus is sensory cortex. Leg area, head area. It means in the brain, in the cerebral cortex, body is hanging upside down, leg area is the top and the head area is the bottom. Now this part of the brain, this is being supplied by anterior cerebral artery. Anterior cerebral artery. Point to be noted, this leg area is supplied by the anterior cerebral artery. So definitely, suppose this is the left side of the brain what I've shown you. If this artery is gone, so what will happen? There will be right-sided contralateral weakness in the legs. Of course, leg weak will be much more than the arms. Why? Legs are being supplied by the anterior cerebral artery. Now, just to add on to you, this part of the body is supplied by the middle cerebral artery. Middle cerebral artery. So, in case of involvement of middle cerebral artery, this will happen in anterior cerebral artery. But in middle cerebral artery, arms weakness will be more than the leg weakness. This is middle cerebral artery. Got it? Now, extra point that you got to understand. Let's learn a little bit more extra. This part of the brain is so-called is a part of frontal lobe. This part is for area of social behavior and personality. So when the anterior cerebral artery involvement is there, this get disturbed. This get disturbed, the patient has antisocial behavior. Antisocial behavior. If you get this line, if you get this line that there is antisocial behavior is there, you are dealing with anterior cerebral artery infarction. Of course, leg weakness is the one more than the arm. But in middle cerebral artery, invariably, speech involvement may be there. Why speech? Speech center are in the left side. Left side. Speech center are like this. We all know very well, of course, not here, this one. So we have a Broca speech area. Let me draw a straight diagram for you. Yeah, this is the, okay. We have a Wernicke speech center. It lies in the superior temporal gyrus. And we have a Broca speech area. It lies in the inferior frontal lobe. Inferior frontal gyrus. Okay. This whole is being supplied by the middle cerebral artery, MCA. Okay. And these centers, they lie on the left side. So whenever left-sided middle cerebral artery will be involved, it leads to aphasia. Aphasia will be a feature when the left-sided MCA is involved. Aphasia. There will be right-sided leg weakness, right-sided arm weakness. Right-hand arm will be weak and there can be homonymous hemianopia. Why? It may involve the visual tract also. It may involve the visual tract. So classically, when they talk about aphasia, they are talking about middle cerebral artery on the left side. Okay? So with this background of basic concept, now we come back. So friends, we are getting a patient, 70-year-old woman, stroke, right-sided sensory loss, arm more than the legs, and right-sided homonymous hemianopia. So what we are dealing with, right-sided, okay? So we are talking about, remember that he has arm weakness is more than the leg weakness, and that we see in middle cerebral artery infarct only. No other condition. In anterior cerebral artery, it would have been leg weakness more than the arms. None of the other artery involved can lead to this type of problem. Okay. So in anterior cerebral artery, it is leg is more than the arm. Posterior cerebral artery, it lead to more of a vision problem. It does not lead to arm or leg weakness. It does not lead to. Pica is altogether a different entity. We discuss in great detail, so I don't need to elaborate Pica. Yeah, I must talk about lacunar infarct. This is very frequently asked question. So let's talk about lacunar infarct. Well, for that we list the basic concept about anatomy of the internal capsule. This is like this. Internal capsule, we all know very well, in internal capsule, we have an anterior limb and we have a posterior limb. Yeah. We also know that in the posterior limb, we have a motor cortex, sensory cortex, motor fibers, sensory fibers. They are coming and going from the motor fiber are coming from the cerebral cortex, and sensory fiber they are going to cerebral cortex. Sometime in these small arteries which are supplying this area or this area may be involved individually. If this artery which is supplying the motor fiber are involved in internal capsule, it will lead to pure motor weakness. Similarly, it may involve the sensory fiber. It will lead to pure sensory loss. And this localized loss is known as lacunar infarct. Right? Lacunar infarct will be there. But in this, if the lacunar infarct is there, it will lead to complete contralateral hemiplegia or complete contralateral loss of sensation. Right? Complete loss will be there because every fiber has been involved. So in our patient, it was not complete loss. This cannot be lacunar infarct. Right? So I hope you are clear about this question also. Question 13. Question 13, 69-year-old woman. One thing you must have noticed that stroke patients are usually elderly people. Unsteady gait, nystagmus, loss of pinprick over the right side of the trigeminal distribution, sensory loss is on the left side, left leg, sensory loss on one side, that is, and in the face, the fifth nerve on the same side, and the rest whole body is on the other side. This again enhanced nystagmus that indicate cerebellar feature. So we are getting ipsilateral cerebellar feature, nystagmus, and we are getting ipsilateral fifth nerve palsy, contralateral loss of pain touch temperature. This is so-called again lateral medullary syndrome, and now the answer shall be the problem of nystagmus is on the right side, so it will be right pica, right side. Remember, sensory loss is on the contralateral side, left side, and the face is on the right side. It is right-sided lateral medullary syndrome. Question 14, again 61-year-old lady, sudden onset of weakness. So that really right lower leg. So it is a stroke. As per definition, anything sudden onset in neurology is vascular phenomena. She had 2 episodes, 2 days, but resolved within 1 hour. Oh, she is a case of TIA, transient ischemic attack with a deficit last but resolved in 24 hours. It is ischemic. Okay. And right, problem is on the right leg. Right leg is there. Transient ischemic at leg area is involved. Which artery is involved? I don't think I need to elaborate. It is right, it's anterior cerebral artery. Which side? It is left-sided. Why? Leg weakness is there. They don't mention about arm weakness. Leg weakness occurs in anterior cerebral artery. Posterior cerebral artery does not involve the leg area. These, none of them supply the leg area. So straight away, we don't need to rule out. It is a straight direct question that we are dealing with anterior cerebral artery lesion. Lovely question. We are getting a 65-year-old female. Right hemiparesis, stroke is there. She has fibrillation, which can predispose to embolic phenomena. It can predispose to embolic phenomena. CT scan confirm ischemic stroke. Okay. And aspirin is given. The first drug always given in ischemia is aspirin. Now warfarin, this is again, patient has atrial fibrillation. So we need, and of course in atrial fibrillation is there, that embolus must have come. Embolus must have come from AF. We want to take care of the embolus in the AF. It should not come. So for this we want to give warfarin. Point to be noted, if you have to start anticoagulant, start after 14 days. Very, very important line. We never start immediately. We never start after 7 days. It has nothing to do. Okay. Nothing to do. And point to be noted, it is mandatory to confirm that it is ischemic stroke. Remember, here he write very clearly, it has been confirmed. CT scan confirm ischemic stroke. Then only you will give. And of course, patient is there. And you have to start warfarin, never immediate. And in a stroke unit, CT scan will be done. So stroke done, CT scan done, no hemorrhage, start warfarin for AF, but after 14 days. Okay? After 14 days. Question number 16. 60-old man, sudden dizziness and vomiting. Okay? Difficulty in standing. vertical nystagmus, hypertension and hypercholesteremia. Well, elderly man coming to you with sudden onset of dizziness and vertigo, and he's not able to stand also. Oh. And there is vertical nystagmus is there. Patient has hypertension and hypercholesteremia. They indicate what? Increase atherosclerosis. Which can predispose to stroke. The only finding is difficulty in standing. Vertical nystagmus. There two findings, they indicate the patient has cerebellar lesion. Now, and patient has a stroke. Now, let me tell you how to investigate any case of stroke. Let's learn the basic concept. In stroke, when patient, what criteria? Sudden onset of focal deficit is stroke. First thing is non-contrast CT scan. Is the first thing to be done. Always learn the Guru Mantra. Why? Why we want to stroke? And we learn the basic concept. 80% are ischemic stroke and 20% are bleeding or hemorrhage. Right? But we are going for CT scan. In ischemic stroke, this CT scan in the first 24 hours will be normal. Okay, and 80% ischemic, then why you want to go for non-contrast? Because CT scan can pick up bleeding much better than MRI. So we do CT scan to rule out bleeding. So if the patient has stroke and in the first 24 hours, CT scan normal, so we are very comfortable that we are dealing with ischemic stroke. We can start aspirin immediately. But if the patient has a hemorrhage, then we can never start aspirin. Point to be noted, speaking second time, we do CT scan to rule out hemorrhage so that we can treat on the line of ischemia. This is a golden rule. So, patient has come with the stroke, we'll go for CT scan immediately. Straightforward. There's no need to use any other thing. And thrombolysis, no way. You have to first confirm. You first confirm that we are dealing with stroke. Sumatriptan for angina, this for vertigo, this for the positional vertigo. So none of them. The answer is urgent CT scan, non-contrast. We never use contrast in stroke. Contrast we use for some brain tumors. For stroke, we always use non-contrast. Okay. 53-year-old lady, sudden onset of left-sided leg weakness, arm and leg. Oh, she has come with sudden hemiplegia, it is stroke. Our basics are clear. Atrial fibrillation is there. Aha. Right? So, first line investigation, what you will do? Non-contrast CT scan. The basic concept. Point to be noted. Atrial fibrillation is there. That means embolic phenomena has occurred. Okay. So, golden line what we learned in the previous question. For any stroke case, first thing to done is non-contrast CT scan. No other investigation needed, so no need to discuss this. Straightforward answer is non-contrast CT scan. So non-contrast CT scan is the first line investigation for a case of suspected stroke. Lovely question. Beautiful question. Quite possible that 76-year gentleman, right hemiparesis stroke. CT scan shows ischemic stroke and aspirin started. As usual, the first thing we start is aspirin. Now, what he says in the management of the acute phase, which will not be corrected. I hope you have read this question very carefully. If not, I still give you 30 seconds. What he says, which of the following you will not like to be intervened? I give you some time to answer your question quickly. The answer is high BP. Nice guidelines, they say, if the BP is high, don't touch it. Don't touch it unless you plan to thrombolize. Then only you like to go for BP below, systolic BP below 180. That also 180. Otherwise, for the nice guidelines, everything what I am speaking as per whatever I have discussed so far is all based on the nice guidelines. Glucose is to be maintained in the normal temperature, oxygen saturation normal, everything to be in the normal range. That you have to manage. But BP is not to be. So let us see what the nice guidelines say. Hypertension should not be treated in the initial period following a stroke. Write down this line. In the initial period, point to be noted very carefully. Unless complication develop like hypertensive encephalopathy. The patient has encephalopathy or we are planned to going for thrombolysis, then we'll do something. But otherwise, leave it is. Other parameter, but I told you glucose, temperature, oxygen saturation are to be kept in the normal range. Okay, and I will be talking more about this BP management in the next question also, coming question. But as of now, something very shocking or unbelievable is the reason behind that, which I am going to discuss in a couple of minutes only. 19. Left 54-year left hemiplegia 5 hours ago, and by now we are clear that we are dealing with stroke. Okay. Dense hemiplegia is noticed. Urgent CT scan is, there are no abnormality. CT normal. What is the most appropriate next management? Aspirin. The point I discussed in the previous question. So, nutshell, summary of any case of stroke. What is the first investigation? Non-contrast CT scan. Next, if CT scan is normal, what you do? Give aspirin. 2 things. But if the CT scan shows bleeding, don't give aspirin. Only 2 keywords, 2 golden line to remember. Write down. In a case of stroke, the first line investigation, non-contrast. And if ischemia, give aspirin. Okay? Give aspirin. Is an antiplatelet drug. Enoxaparin is a anticoagulant. We don't give. Etiplase is a thrombolytic we use, but not as a first line treatment. Not as first line. Dexamethasone we use only in brain tumors. To reduce edema. Warfarin is not a first line treatment. So answer is aspirin. So write down the golden line to remember. First investigation, non-contrast CT scan. First line treatment for ischemia, aspirin. Golden line to remember. Cannot afford to forget these two lines. Okay, so now let me discuss more about management. So, as per NICE guidelines, let me discuss in great detail as I told you. So, NICE guidelines 2019. What he says, it is true that patient has come to us with stroke. We have to do a lot of intervention, vagara vagara. But before that, take care of the blood glucose, hydration, oxygen saturation and temperature. They should be maintained within normal limits. Okay. This I discussed in the previous question also. The question was in the before this that regarding BP, no problem, but regarding it has to be temperature and oxygen saturation, glucose has to be taken care. Okay. So this point we discussed in the previous question also. In the previous question there was regarding BP. Now look what NICE guidelines say. It should not be lowered in the acute phase. Remember, he don't take the carry home message that never treat hypertension. He never say. Acute phase, don't touch it unless there is some complication like hypertensive and cencephalopathy, which I told you in the previous question. Give aspirin. Maybe 300 milligram, maybe oral or by per rectal. Due to any reason, if you are not able to give orally per rectal, provided you have ruled out hemorrhagic stroke. So that's why non-contrast CT scan the first to be done. So we got an answer in this question also. Why not to touch about blood pressure? Now, atrial fibrillation, which we have to give anticoagulation. So we should not give until 14 days have passed. At this point I discussed in the previous question also. We want to give warfarin. We want to give warfarin to prevent further clot, embolic phenomena. But that should be only after 14 days. After 14 days, not immediately. And statins, cholesterol is the one. Something very interesting. If the cholesterol value is more than 3.5 millimole per liter, you can start statin. But again, something golden line to remember. What the NICE guidelines say that many people try to start after 48 hours. After 40, statin, why? Because it can lead to hemorrhagic transformation. Patient has come with ischemic stroke, but they try to start not immediately, but after 48 hours. Point to be noted. So let me tell what I told you so far. Start aspirin. So now stepwise, do immediately non-contrast CT scan. If ischemia, start aspirin 300 milligram. Okay. And then you want to start warfarin, do after 14 days. And if the lipid is high, start statin after 48 hours. Okay. Now thrombolysis is the big thing. Now we do thrombolysis. First of all, we use only one, that is LT place, is the only which have been approved, only approved for stroke. Point to be noted very carefully, in coronary artery disease, we use like streptokinase, urokinase, but we don't use this in CV, we use only LT place. But when the patient has come within 2.5 hours, okay, within 2.5 hours, and that also provided we have ruled out hemorrhage. That means you will do CT scan, patient has a stroke 3 hours back, he has come to you with 3 hours, go for urgent CT scan normal, then you can plan for thrombolysis. The window period is only 4.5 hours. Okay, 4 hours and 30 minutes to be more precise. 4 hours and 30 minutes. 4.5 doesn't mean 4 hours and 50 minutes. No, it's 4.5 hours. 4.5 hours to be more precise. So, thrombolysis within 4.5 hours, CT scan says ischemia. Now, what are the contraindications of thrombolysis where you will not do thrombolysis? Previous intracranial hemorrhage, absolute contraindication. Patient had a hemorrhagic stroke in the past, but now he has come with ischemic, don't do this thing. Seizure at onset of stroke. Normally, seizure is not a feature of stroke. But if due to any reason it is there, the seizure occurs usually in bleeding. In hemorrhagic, it may occur, not in ischemia. So, seizure on the onset is 99% you are dealing with hemorrhagic stroke. Intracranial neoplasm is there, which is causing this, it can lead to bleed. Subarachnoid hemorrhage, don't use it. Of course, any bleeding, no doubt about any bleeding, intracranial, subarachnoid, any bleeding, don't use it. Stroke or traumatic lesion in the preceding 3 months, there is a history of head injury, don't use it. Lumbar puncture has been done in the last 7 days, don't do it. Already puncture site is there, if you do, it can bleed. GI bleeding in the last 3 weeks. Patient may have esophageal varices. Okay, and the patient had for last 3 weeks. Active bleeding already occurring somewhere, pregnancy, varicose bleed, what I told you. And now come the gold medal. Most important is uncontrolled hypertension. Point to be noted. He's not going to ask you anything else. This is the only thing what he's going to ask you. Well, it is really confusing. In the previous slide, what he said, the patient had, there were BP of 210/110. And he said, don't touch it. In the acute phase, don't manage it. And that time I told you the only indication, but if the BP is very, very high, then you cannot do thrombolysis. So now the time you have to reduce the BP to little bit before you thrombolyze. But if same patient, you don't plan to do thrombolysis, then you will not touch this also, unless there is encephalopathy is there. Now, relative contraindication include concurrent anticoagulation going on. INR is more than 1.7. Patient is already taking warfarin. And the INR 1.7, don't do thrombolysis. Bleeding tendencies, hemorrhagic retinopathy, diabetic retinopathy should be ruled out because it can lead to bleed and it can lead to retinal detachment. RD stands for retinal detachment. Okay, major surgery in the last 2 weeks, they are all relative contraindicated. Out of all these, not possible to remember everything, but this is the single most important thing that is very, very important for all exam point of view. Now we talk about thrombolysis. We have to do within 4.5 hours with no contraindication as we discussed. Now we have additional things, thrombectomy. You want to refer the patient to interventional radiologist, and he is going to do thrombectomy. Okay, what we call as mechanical thrombectomy. You are actually removing the clot, what we call as mechanical. This is a new thing which has been added by the as per NICE guidelines 19. Okay, so let's learn and talk more about NICE guidelines. Okay, but all depend on clinical status. Point to be noted. Decision depend on how the patient is in the what situation is there. Not that every patient is fit for everything. So let us see when you will like to do. If within 6 hours. Point within 6 hours. But if it comes before 4.5 hours, then you can go for thrombolysis with. So in that scenario, you will do with intravenous thrombolysis. So point to be noted, if he comes before 4.5 hours, thrombolysis plus thrombectomy, TT thrombectomy and TL is thrombolysis, both you will do. But if he comes between 4.5 to 6 hours, the window period for thrombolysis gone, then you do only thrombectomy. Only thrombectomy. Okay? Right, sir. But will you do like this? No way. No way. We have done CT scan, non-contrast. It is normal. There is no bleeding. Now you plan to go for thrombectomy. Will you go straight away? No way. You have to confirm by CT angiography or MR angiography. Let's come back. Let us say patient has come to me after 3 hours of stroke. So I will do we give thrombolysis. Of course, I've done first is non-contrast CT scan. Non-contrast CT scan. And it is normal. That means ischemia is there. It's the first thing to be done. First thing to be done. After that, I give thrombolysis. He has come within 3 hours. And after that, I'll go for MR angiography or CT angiography. And if I can locate the clot, now I'll go for thrombectomy. Suppose he come between 4.5 to 6 hours, then you will do this. Then you will not do thrombolysis because the time is already gone more than 4.5 hours. Then we can go for thrombectomy. Okay. So I hope you understood. Time is money. Something, well, suppose the patient come after 10 hours. 10 hours, you go for CT scan. CT scan is normal, that means there is no bleeding. Remember, repeating second time, we do CT scan to rule out hemorrhage. No hemorrhage, but why? Why not MRI? Reminding you, CT scan is better. CT scan is better than MRI to pick up any bleeding. To pick up any bleeding. Right? That's why we have been talking about non-contrast CT scan. Well, it's 10 hours now. 10 hours. And now 10 hours, even the 6-hour period is gone, is more than. So between the age time of 6 hours to 24 hours, we can go for thrombectomy also. But what we do, we have done the cerebral angiography, and we find that there is some potential area, or MR angiography, we find there are some potential areas which has not necrosed yet. It's not dead, although the artery blocked, still the area is not dead. Then we can salvage. We can do salvage. Then we can go for thrombectomy in such case also. But again, all depend what the patient situation and what your angiography says. Yes, we have certain potential area we can save. Go for thrombectomy. So to conclude what I discussed, plain CT, normal, within 4.5 hours give thrombolysis, and after that go for MR angiography, go for thrombectomy. After 4.5 hours, CT scan normal, ischemia is there, and you do MR angiography. You plan for thrombectomy if you find some salvage possibilities there. Okay? I hope things are clear to you. Now, secondary prevention. This again very important. Patient is there with you, and now a time has come when you want to discharge the patient. Definitely. Discharging a patient, we have to plan for secondary prevention. What the nice guidelines, latest guidelines say. Nice guidelines. This is when you are planning to discharge. And now you have to listen to very carefully. As per nice guidelines, clopidogrel is now recommended ahead of aspirin and modified release dipyridamole. I repeat again. At the time of discharge, they say clopidogrel is a better drug as compared to combination of aspirin and dipyridamole. Point number 1. Point number 2, you will give a combination of aspirin and dipyridamole if clopidogrel is contraindicated or not tolerated. Point to note it. First thing is clopidogrel. If not, due to any reason, contraindication there, patient is allergic, not tolerant, then you give a combination of aspirin and dipyridamole. Previous guidelines, they say give dipyridamole for 2 years, but now the latest nice guidelines say you can give lifelong, so that no longer limited to 2-year duration. Okay? Understood? Now, third scenario, we have a patient, we can give alone if there is some contraindication of giving aspirin and clopidogrel. You cannot give clopidogrel, you cannot give aspirin, then you give alone dipyridamole. So friends, I repeat again. Prevention. What is the first drug you will give? Clopidogrel. If that is contraindicated, whatever reason it may be, then you give a combination of aspirin and dipepramol. Third, if there is any reason that you cannot give clopidogrel or maybe you cannot give aspirin, then you give dipepramol. This is secondary prevention. With this background, we come to next question. We got a patient, 71-year-old, ischemic stroke, intolerant to clopidogrel. What next? Answer is aspirin, dipepramol lifelong. And that stop after 2 years. This is gone. This is gone. So I don't think I need to discuss more. I've discussed everything. No need to stop for 2 years. Alone, no, we only give when even if patient cannot tolerate aspirin also. Aspirin lifelong is not the answer. Warfarin, no. Aspirin and dipepramol are the lifelong. Okay. 21. Ischemic stroke patient, and he has come with the thrombolysis window outside the window. Started with aspirin. Remember, first drug is always aspirin. But when we plan to discharge for secondary prevention, the answer is clopidogrel and statins. Why? Cholesterol level is 3.9. Remember, clopidogrel is the best drug for discharge. For hyperlipidemia, we give statin, but after 48 hours. And here we are discharging the patient. Definitely, it is already after 14 days. So now we can very well give clopidogrel plus statin. Right? Right, sir? I hope your things are very, very clear. Very clear why we are giving clopidogrel and statin. Question 22. 64-year-old man, 4 hours, speech difficulty, hypertension, atrial fibrillation, cholesterol high, smoking, and he has dyspnea, dysphagia, and he has right-sided hemiplegia, sensory loss, homonymous hemianopia. Okay. What is, can you tell me what is this he's talking about? Right-sided hemiplegia with aphasia. He's talking about left-sided middle cerebral artery lesion is there. Okay. I hope you remember. In MCA, there is contralateral hemiplegia. Speech center is on the left side. So if left-sided lesion will be there, that lead to speech disturbance, and the right-sided weakness will be there. So we got, okay, CT scan, angiography, and they excluded hemorrhage. There is no bleeding. Ruled out. What is the next management plan? We would like to give thrombolysis. He has come within 4 hours. Within 4 hours he has come to us. Your concepts are clear. Now this is an ideal candidate for thrombolysis as well as mechanical thrombectomy. Suppose the time in this question, the time was 5 hours. Suppose the time given was 5 hours. Okay. This was 5 hours. Then you have to go for only mechanical thrombectomy. But here the time is 3 hours. This is the best answer. Question 23, 72-year-old man, hypertension, dense right-sided hemiplegia. Okay, and at 21 p.m., that is at 9 p.m., he was perfectly around. But now he has dense hemiparesis, right arm, lower face, increased tone and sensory loss, plantar are downgoing, dysarthria, pupillar equal, CT scan is performed. CT scan shows area of left middle cerebral artery with mild evidence of swelling in the left parietal area. Reduced perfusion from the proximal left cerebral artery suggests of subacute infarction of the left middle cerebral artery. No evidence of bleeding. ECG shows atrial fibrillation. What to do? What to do this patient? Oh. This patient problem had 8 a.m. and 9 p.m. long gap of 13 hours there. And there is some area of subacute infarction. That means it is still salvable brain tissue is there. It's not a subacute infarction. That means what he want to convey the message is we have certain area which we can salvage. Okay, and there's no hemorrhage is the ideal candidate for thrombectomy by the interventional radiologist. The point I told you, we can go up to 24 hours, right? Will you do thrombolysis? No way, time is gone. Apixaban has no role at the plane. Aspirin is an antiplatelet drug. It will not save the brain. So answer is this. There is no role of decompressive craniotomy. This we do only when the severe edema is there. Some brain herniation going on. Brain herniation going on, then we can think, but not in this situation. Hence the best answer is thrombectomy. 58-year-old, unable to move his right side, slurred speech, right-handed facial drop, complete paralysis of right side, CT scan rule out hemorrhage, and CT angiography confirm proximal anterior circulation with CT perfusion showing limited infarct core volume. Okay, and this we noticed when he woke up in the morning, right? So again, patient has come to us with the problem of a point to note it, he has ischemia. Why? How do you know? CT scan has ruled out, but CT angiography is showing limited infarct core volume. That means we still have brain area that we can salvage. Long time, then best answer shall be thrombectomy. Right? Again, same option what we discussed, no use of, we have to save the brain because there is some salvable brain tissue is there. So within 4.5 hours, go for thrombolysis, and if you can, and after that, go for thrombectomy. So the golden line, what the nice guidelines are. for thrombectomy in acute ischemic stroke, 6 to 12, 24 hour may be considered. 6 to 20, up to 6 hours is the best. But 6 to 24 hours is confirmed if potential to salvage brain tissue. And that you cannot decide unless you do CT perfusion or diffusion weighted MRI, so that we know whether we have a salvable brain area or not. So to conclude the show, 6 to 24 hours CT perfusion studies or diffusion weighted MRI, and if they show limited infarct core volume, then you can plan for the mechanical thrombectomy, 6 to 24 hours. 68-year, left-sided weakness, high BP, cholesterol high, 9:30 a.m. and now it is 2:30 a.m. In area of infarction, CT angiogram confirm occlusion. I think it is 9:30 a.m. It is 2:30 p.m. It is a gap of how much time? 5 hours. The window period of 4.5 hour gone, but 5 hour. Then answer is thrombectomy is the best answer. So it means, point to be noted, when they are asking, the MRCP people are asking question, they are giving a definite clue to you. Like in this question, 9:30 a.m. now 2:30 p.m. 5 hour, thrombolysis gone, thrombectomy is the only thing that we can do. And remember, he says that CT scan area of infarction, he has confirmed is no bleeding is there. Go for thrombectomy. 26, 74-year, sudden onset of left weakness, sudden onset is a stroke, okay, hypertension, diabetes, hypercholesteremia, all indicate. One more thing, whenever he write about hypertension, diabetes and cholesterol, all are indicated toward atherosclerosis. That means more of a ischemic stroke is there. Okay, and ischemia, MRI confirm proximal circulation. What is the next best? Okay, when he is come to us, okay, now something 1 hour ago. So 1 hour ago, I think we have to go for thrombolysis. So enough question discussed to make you concept very clear. I'll give you summary later on. 27. This is a good question. We got 83-year-old, periparesis, hypertension, high BP, cholesterol. Disability, which of them? This is Barthel index. What is this? It is scale to measure disability or dependence in activity of daily life in stroke patient. This is Barthel index. So just write down disability criteria in a case of stroke. Rockwood frailty. It find high area in hospital mortality. Okay. It talks more about the patient is hospitalized and how sick he is, critically ill patient, whether he'll survive or not. That is Rockwood frailty. Then we have child poke that we use for hepatic chronic liver disease. Rifle criteria is for acute kidney injury. Waterloo score is for development of bed sores. So if I have to give you summary, child poke is for chronic liver disease. Acute kidney injury. Bed sore formation. And this is for mortality in hospitalized patient. Okay. 28. 35-year-old. Aha. So far, all patients on stroke were about 70, 80, blah, blah, elderly. We are getting young man, 35 years. Migraine and hemiparesis is there. History of stroke and migraine in the family. CT scan indicate hypodense area and CADASIL. This is notch 3 mutation. What is this? Let's learn more about CADASIL and then again I'll come back to this question. First of all, CADASIL is a short term. Note down what it stands for. Cerebral, autosomal, dominant, arteriopathy, subcortical, infarction, and leukoencephalopathy. Point to be noted, it is a type of arteriopathy, subcortical. It is a dominant. It means what? Family history will be positive. So far we have not got this entity anywhere. Since it is autosomal dominant, is a familial, so that's why it is occurring at the age of 35 years. Normally all atherosclerosis, and remember there is nothing like hypertension, diabetes, nothing. There is nothing to predispose to atherosclerosis. Since it is a familial phenomenon, okay, and he also said it, family history of stroke. So whenever you are getting family history of stroke, think about CADASIL. And it will be supported by a young age. The two things, family history positive, young age, think about CADASIL. And this is due to mutation in the notch 3 mutation. Notch 2, this is seen in Crohn's disease. They are seen in Crohn's disease. And FXN mutation, this is seen in Friedreich ataxia. GLA mutation, this is seen in Fabry's disease. And this is seen in Brugada syndrome. Brugada syndrome. So this summary. So notch 3 is for CADASIL and node 2 is for Crohn, FXN for Friedrichs, GLA for Fabry's, and SCN5A for Brugada. So friends, now if I have to summarize the whole show for stroke management, any first thing you will do is non-contrast CT scan. If it is normal, that means rule out bleeding. then you have to go for, if it come within 4.5 hour, go for thrombolysis as well as mechanical thrombectomy. Third, if he come after 4.5 hours and between 6 hours, go for thrombectomy. And thrombectomy you can do up to 24 hours, but that will do, again, thrombectomy is never done without any time. You never do without doing CT angiography or MR angiography. It's mandatory. And of course, between 4.5 to 6 hours, you can plan, you should do thrombectomy. You can save the brain. But after 6 hours, all depend whether you can see that it's salvable brain is tissue or not. Accordingly, you plan it. Accordingly, you do the thrombectomy. Okay. And the first antiplatelet is always aspirin. At the time of discharge, the best antiplatelet is clopidogrel with statin. Statin will start after 48 hours of admission. And if clopidogrel, then aspirin and dipyridamole. If aspirin and clopidogrel both are not, then go for dipyridamole. So I hope it was a good exercise. You learned a lot. Thank you very much.